University Hospital and chair of the Global Outbreak Alert and Response Network hosted by World Health Organization. If you have a question for the panel at any time during the webinar, you can use the Q&A box to type in your questions. Questions will be addressed at the last segment of the webinar. I would now hand over to Professor Fisher. Professor Fisher, please.
Thanks, Wendy, and welcome to all listeners from Singapore and France and perhaps other places. Also like to welcome all the panelists, and what we're going to be talking about today and hearing about more of is how these two countries are balancing the medical, economic and socio-cultural aspects of this pandemic. We've got 5 speakers, as mentioned. The first will be Professor Y.Y. Teo, who's going to give us an overview of the situation in Singapore. He's Dean of the Saw Swee Hock School of Public Health, NUS. Prior to his deanship, he was the founding director of the school's Centre for Health Services and Policy Research, and also served as the director of the Centre for Infectious Disease Epidemiology and Research from 2015 to 2017. The next speaker will be Professor Frédéric Batut. He's going to give us an overview from the situation in France. He's Professor of Immunology and Vice Dean for International Affairs at the Faculty of Health, University of Paris. He's also head of Clinical Immunology Laboratory, the Immunology Laboratory at Cochin Hospital, APHP in Paris. Professor Batut also serves as Medical Director of the Hôtel Dieu de Paris, the oldest hospital in Paris, founded in 651 AD. The next speaker will be Professor Raphael Porcher. He's going to be speaking on where we are now in terms of knowledge about treatments for SARS-CoV-2 infection, and also some public health perspectives. Professor Porcher is an Associate Professor of Biostatistics at University of Paris. He's co-director of the Centre Virchow-Villemay, Paris, Berlin. Dr. Porcher is involved in applied clinical research, including clinical trials, observational studies, and prognostic studies, with a special focus on personalizing care. And believe it or not, I did try and practice these pronunciations beforehand. Professor Danny Quah will be speaking on economic perspectives. He's a professor in economics and dean at the NUS Lee Kuan Yew School of Public Policy. His research on equality and income mobility characteristics and the range of experiences across economies to suggest that a single narrative of inequality is unlikely to be correct or helpful. And our final speaker will be Dr. Etienne Nguyen. He's going to give a broad panorama of sociologic issues concerning the lockdown and the reopening on sociology perspectives. He's from the Centre for Sociology of the organization Paris Institute of Political Studies in France. His research focuses on drug markets and local public health policies. He's starting a research project on how French local and regional governments manage the COVID-19 pandemic and the lockdown. So that's a bit of a mouthful, but that's the talent of the speakers that we're going to be listening to. We'll be taking all the questions at the end. We welcome the questions, and please submit them electronically, and we'll get to as many as we can after all the speakers have finished. So if I could start with you, Prof. Teo from School of Public Health in Singapore.
Thanks very much, Dale. So welcome to everyone. I'll be speaking over the next 10 minutes about the situation in Singapore. And 10 minutes is a really difficult task to wrap all that has happened in the past 6 months into this 10 minutes. But I think what it's important to highlight is that in Singapore, one of the key experiences that we had suffered badly in 2003 was from SARS. And the SARS experience actually gave us quite a lot of preparation for COVID-19. In Singapore right now, we have slightly less than 45,000 cases, of which active cases, there's less than 5,000 at the moment, of which 2 of them are in intensive care unit and 200 of them are in hospital wards. The vast majority, the rest of the 4,000 over, are actually in isolation facilities in the community, but it is managed by the government. So anyone that has been diagnosed with COVID-19 is isolated from the rest of the community in facilities that are either managed by the government or in hospitals. We have a very good death rate, as unfortunate as it sounds, but our death rate has been fortunately very, very low at the moment, 26 out of a possible infection number of 45,000. The situation in Singapore can be roughly summarized as there are two waves that are happening. One is what's happening in the general community, infecting people that are going to schools, going to work. But there is a second wave that is affecting migrant workers living in dormitories. And the number of people in the community that have been infected have been maintained at a very low rate at the moment, averaging between 10 to 15 people in the community presently. In the dormitories, we have reduced the numbers from a daily high of about 1,000 over cases. Right now, it's between 100 to 200 cases every day. So the way that Singapore has contained the spread within the community, as well as in the migrant worker dormitories, essentially rely on three broad principles. The first principle is really to try and find the cases as early, as quickly as possible, track them, perform the necessary contact tracing, perform the necessary swabbing and testing, and for people who are found to be positive, we immediately isolate them from the rest of the community, either in government facilities that I talk about or in hospitals. For those that have been in contact with people who turn positive, the contacts are similarly isolated and quarantined as early as possible. And that has actually helped to reduce the amount of time that people with the infection circulate in the public. And we have seen that the data suggests in early February, it takes on average between 5 to 10 days to pick up someone who are symptomatic and who subsequently turn positive. And now actually it's an average of between 2 to 5 days. So we have tremendously reduced the number of days that people with the infection are circulating in public. The second is actually relying on evidence to decide on whether it is on clinical management. I talk about how we reserve the hospital facilities for high-risk groups and severe cases. The vast majority, the science tells us that most of them actually have very mild symptoms, and they can be managed in a community facility with the necessary medical care. The second approach on the use of evidence is really around how we manage populations in terms of should we close schools, should we close workplaces, and that is where the use of models, mathematical models, statistical models have been very much at the forefront to guide the policymakers in terms of what to do at the population level in terms of minimizing the spread within the community. And the third is really having an ability to make use of information and data and evidence that is emerging very rapidly from different parts of the world, collate this kind of information in a manner that our policymakers are able to interpret this evidence. So there are weekly reports that have been generated for policymakers around different issues. In the early days, it was around clinical characteristics, around containment measures, around diagnostics. And right now, there are weekly briefs around therapeutics, vaccines, exit strategies, and even lockdown strategies that are produced weekly for policymakers to make sense of. The third principle is really important on communications. And I think Singapore, what the government has done is to have a government managed platform which conveys three kinds of information. The first is what is the situation in Singapore at the moment. The second is what are the regulations, because new rules are happening all the time, especially when we start to ease some of these lockdown measures. There are new regulations and reminders that are put in place. The public need to be informed rapidly and consistently from a trusted source. And the third kind of information is actually what individuals like you and me can do to minimize the spread amongst my family members and in the community that I mingle in. In terms of border controls, Singapore, we have maintained very strict border control from the very beginning. As early as the 2nd of January, there were temperature checks, and this was subsequently escalated. Right now, the border is still closed to all short-term visitors, and any returning locals need to spend a 14 days mandatory quarantine, either in government-appointed hotels or at home for if you're returning from countries with very low risk of community transmission. There's currently a fast lane or green lane arrangement with China, but it is only for essential business travel. I think we have talked a lot about the public health strategies that Singapore has adopted, but I think it's important to highlight that there are contextual elements that allow Singapore to execute some of these measures that we talk about. The historical is one where we have our experience with SARS. I think the social and cultural part in terms of the trust, the community-spirited population actually helps to impose some of the more stringent measures that Singapore has to put in place. There's economic fiscal measures that have been put in place to protect livelihoods, and I know my colleague Danny Kwok will actually talk about this. And I think one very important aspect is the political outlook, because when you have a government that is fairly stable, this is where the government can invest in long-term measures for public health, as opposed to governments that are changing rapidly, and that is where they aim for quick bangs because they need to show results within a short span of time to guarantee re-election subsequently. So this long-term outlook has been at the forefront of public health for many countries with stable governments, and we see this remarkably in the Eastern governments. And I think there is a need for us to shift the narrative to now focus on outcomes, because when we start to talk about COVID-19, there is this focus on the number of people that are infected daily. And I think that that is not a very appropriate focus, especially when the ability to track and trace remains at the forefront when we're talking about lifting the measures, minimizing deaths and complications, protecting healthcare workers. These are some of the basic issues that we should be focusing on as we start to decide are countries ready to lift some of these lockdown measures and they start to plan their exit strategies. What are the fiscal support for individuals and businesses, protecting vulnerable and neglected populations? Some of this remain at the very core of systems when we start to talk about the approach that government needs to take to focus on what they could put in place to protect the population. So with that, I think I will stop here and I'm happy to take questions later on. But over back to you, Dale.
Thanks, Wai. That was very clear. Could I now pass to Professor Frédéric Batut to give us an overview of the situation in France? Thanks, Professor.
Thank you. Share the screen. So thank you very much for providing us with the opportunity to describe the Assistance Publique Hôpitaux de Paris response to the COVID epidemic. So as you may know, the first patients with COVID-19 infection was a Chinese tourist from Wuhan, who came and who was hospitalized in Paris with his daughter on January 24. And since then, unfortunately, the number of cases has increased by huge. And now we have roughly more than 166,000 cumulative cases and 30,000 cumulative deaths. Since the epidemic peak in Paris, in France, roughly in mid-April, the number of cases and the number of deaths that occurs daily tends to decrease constantly. So the epidemic hit France not homogeneously, and so we have first clusters that occurs first in North Paris, in a city called Crépy-en-Valois, and then also in the Far East, in the city of Colmar, and also in the Alps, in a small village called Contamine. It was a British tourists that came back to Italy and to spend some days in vacation there, and but they came back. They came with a COVID infection, but since those first cases, then the epidemic spread mainly in two regions: the Far East of France and the Paris regions mainly. Other major French cities were also impacted by the COVID-19 infections, mainly Lyon, Marseille, and Lille were the main city in France. But as you see, it was not homogeneous, and it was deeply. The impact was mainly in the Paris region and in the Far East. And so in the Paris region, 1/3 of the medical resources in Paris area was provided by the Assistance Publique Hôpitaux de Paris. It's the largest European consortium of hospitals. 39 hospitals belong to this community, this healthcare community. It's 25,000 beds, more than 8 million in and out patients visit hospitals each year. So it's a big consortium. And so all the hospitals are located in Paris and in the suburb, in regions where around 4 to 5 million of people are living there. So regarding the facilities in our hospital, so in the Paris region, we have roughly 1,149 ICU beds, and more than 500 are in the APHP hospitals. We have 2 medical reference centers for infectious disease, one in the North Paris, it's Bichat Hospital, and one in the South, it's Pitié-Salpêtrière Hospital. It's the largest hospital in Europe. It's a very famous hospital. And so how do we get prepared to face the wave? So first, we get lessons from foreign countries, both in terms of clinics and in terms of epidemiology, of course. So in terms of clinics, as you are aware, the WHO organized a mission in Wuhan in early February 2020. And so we have, this mission gave us the first clinical descriptions of the disease and the percentage of highly severe patients. So roughly 6% of COVID-19 infected patients were critical. So this led us to get a bit prepared of what's really going on. And so we also have some epidemiologic observations in China, of course. So the Chinese CDC give us some, epidemiological data, but also because the COVID-19 hits Europe in Italy first, then we can observe what occurs in our neighbors in Italy, and especially in Lombardy. And Lombardy, it's a region in the north of Italy with roughly the same amounts of population of residents as in Paris area regions. And so we came up with three model of three hypotheses. The first hypothesis was then, at the peak of the disease, the number of patients in ICU will range between 100 to 1,000 patients in our hospitals. Then came up some mathematical models, and especially drawn by the Pasteur Institute, a very famous institute in France. And then, they came up with, it's going to be 100,000 people in ICU, and it's going to be 400,000 deaths. So it was, a bit confusing because we have, very different point of view. And so it was very difficult for us to set up a strategy. And so we decided to prepare for the worst. And then we set up some kind of a military organization. And so we set up a clear chain of medical responsibility beyond the traditional organization in department or commission or whatever organization it was already. And so to enable an efficient and reactive operational decision. And so we appoint crisis medical directors that worked along with our CEO. So it was Bruno Rioux and Martin Hirsch, and so they organized everything, you know, with 3 arms: medical material supply, human resources, and medical organization. And in each hospital, we have the same organization with 1 medical crisis director per hospital and 1 administrative directors. And so with that, we were, you know, quite, I don't know, quite okay with this organization. So the first thing we tried to set up was to avoid hospital overwhelming. And because we know that most COVID-19 infections were post-symptomatic, we decided to set up an in-home survey through a telemedicine platform, which is called COVIDom, because we thought it's going to be better for us to survey patients in their home, in their bed, than in our bed in hospital. And so basically each patient tested positive for the SARS-CoV-2 or with typical radiological or clinical signs of SARS-CoV-2 can be registered in the COVIDom platform. 50,000 people were registered during the first 2 months of the epidemic. And they were surveyed based on the daily questionnaire, and based on the answers that come up, we can draw 3 types of flags. So the green flag, if the answer was, you know, quite good, and then, you know, no actions, basically it was see you tomorrow. The orange flag was, you know, then a volunteer calls the patients, and even he can ask a doctor if he needs help. And if a red flags come out of the questionnaires, then a doctor calls immediately the patients, and even a 911 emergency call can be done. Of course, we have performed a lot of biological testing in our hospital. More than 200,000 PCR has been done. In the peak of the disease, more than 50% of PCR were positive. In order to avoid overcrowding of emergency departments, so we have to organize the patient flux, and then we ask patients to call the 911, not to go to the emergency departments, not to go to the GPs. We ask them to call the 911. Then an ambulance can come and take care to the patients. And this was very, very interesting to control the flux between the COVID positive and the COVID negative patients. And during the epidemic, so usually we have 2,000 calls in the 911 per day, and at the peak of the epidemic, we have a peak of more than 10,000 calls. So it was a huge amount of calls, so 10,000 calls each day. So the EMS call start very early, and 15 days before the number of patients came out to the ICU department. So, it was a very early event. And so it's helped us to prepare to the wave we're going to face. And so here, for example, you have in the red line, you have the EMS calls. In the blue line, you have the number of new ICU patients we have each day. And in the gray, you have the cumulative number of ICU patients. And as you can see, the EMS call was the first signal, then followed by the percentage of positive RT-PCR, then GP and ED and emergency department visit, then ambulance, and of course, at the end, hospital admission. So it was this exemplified the organization we set up to welcome the patients with the COVID-19. So here is the size of the wave, basically. So here in blue, you have the cumulative number of ICU patients we have to take care in the Paris area. And in the green line, you have the number of cumulative number of patients we have to welcome in the APHP hospitals. And as you can see, the number of patients tends to grow starting early March. And you know, in the red line was the number of patients we observed in the Lombardy region in Italy. And as you can see in the beginning, during the first 15 days, you know, the situation was very close to the one we observed in Italy. But unfortunately, on March 18, then the situations tend to become, you know, much more worse, and the number of patients increased by huge. And so we have to adapt very rapidly, and so we open a lot of new ICU beds to take care of the patients. And so after 10 days, the situations tend to become better, and the number of patients tend to decline. And the epidemiologists tell us, oh, the number of patients will peak around 2,000. But unfortunately, 2 days after they claim that, the number of patients increased once again by huge. And we go from 1,700 to 2,400 patients in 48 hours. So we have once again to adapt. So we open roughly 368 new beds in 48 hours, and we have to transfer also patients in other regions of France. So we transfer patients by train, by plane, or by ambulance. And so in 6 days, we have to transfer roughly 200 patients out of the Paris regions. So at the end of the day, so more than 7,000 patients have been hospitalized in ICU departments in the Paris regions. Unfortunately, 1,800 patients die in our facilities in ICU. The mean age was 60 years old for the patient hospitalized, and for the patient who died in our ICU department, it was they were a little bit older, in 65 years old. We do not welcome only patients in ICU. We also welcome a lot of patients in all our departments. And at the, as described in this slide, the number of patients we welcome in the Paris region was more than 42,000. So it's a huge number of patients we have to welcome in roughly 8 weeks. So it was the tension was very high on the healthcare system in the Paris region, as you can imagine. The number of deaths, unfortunately, is also huge, more than 7,000. The mean age of the patients who died were roughly higher than 80 years old. And it was this situation during all the period. To face the wave, to support all of this, we need to have some help. And as you see in these slides, the number of external additional supports, the number of volunteers was huge. And so the people come from all over France to help us to take care of our patients. It's 10,000 people, but also we have internal additional support. Of course, everybody cancel his vacations, do overtimes. The medical students, the nursing students were, take part, of course, of all the efforts of the medical professional. And because of this help, then we can face the wave. So how do we prepare from a second wave? So now we have a little bit of experience of what occurs and about the indicators or the predictive markers we have observed in the first wave. And so we have a very careful look of the evolution of these markers, both the slope and the threshold of each markers. And so it gave us a red flag. And so we are very aware of this type of, the evolution of this marker now. They are all red, but we are very careful of, if they tend to increase to adapt very rapidly. We also have a patient tracing program, which is called COVISAN. And so this program tends to interrupt the contamination chain, and each patient who is test positive is isolated in quarantine. And so this system has, so more than roughly 7,000 people have joined this Covisan platform. So in conclusion, so the best way to avoid the second wave is to respect all the social distancing, to wash your hand with hydroalcoholic gels, and to wear surgical mask. And this is a very important, message we have to draw to our citizens. So
thanks, Frederick.
I will stop with, to thank all the people and volunteers who help us to face the wave. So thank you so much, and sorry for being a little bit long.
It's okay. Thanks very much for that. All right, we'll move on to our next speaker, who's Rafael Porcher. Is going to talk on where we are now in terms of knowledge about treatments and a little bit on public health perspectives as well. Thanks, Rafael. Just unmute yourself. Rafael, you're still muted.
I'm terribly sorry. Sorry. So I will try to speak a bit about where we are now in terms of research, knowledge about treatments, and perhaps prevention. We have seen a lot, and in YY talks, many important messages have already been tackled, which is great actually. So COVID-19 was an unprecedented outbreak from a medical point of view, but it was also the case from a research and clinical research point of view. There are currently more than 50,000 papers, mostly on preprint servers, but still more than 50,000 papers on COVID-19. And if you push me, I will even say I don't see how people will be able to synthesize all that work, but that's a different issue. There are also a lot of trials, of clinical trials, more than 3,700 currently registered, and more than 1,200 randomized clinical trials registered. At the same time, we have very few high level of evidence data available yet, and there are, for instance, only 25 randomized clinical trials with results available today, and 60 non-randomized clinical studies. If we add all the observational studies, it's adding 160 more. So there is currently a bunch of data, of more or less high quality data on treatments, but not so much compared to what we will have in the next months. So there have been, so we don't know so much on how to, it's not true what I say. It's not that we don't know, it's that we don't have a lot of high quality of evidence or high level of evidence data on what works for COVID-19. And so there are results for dexamethasone, for instance, but still we are waiting a lot of trial results. At the same time, the clinical experience and the clinical knowledge has improved a lot. And by this improvement, we have seen that the management of patients has evolved. And we have seen that perhaps strategies or interventions that were not targeted at the beginning of the outbreak as a potential relevant solutions proved perhaps a good thing, like high flow oxygen, but they are, since they were not seen at the beginning as a good target for a trial, they are not evaluated properly now. And for instance, there is only one trial in high flow with 60 patients available. So I will try to skip the next thing. I would just want to emphasize that doing trials during outbreaks is difficult. It's difficult to plan a trial shortly. It's difficult to conduct the trial, to run the trial actually. And if you have seen on Frédéric Bateau's slides, the epidemics, the amount of people who have been admitted to the hospitals in Ile-de-France region, for instance, is huge, is impressive, but the timing is very short, and it's about 1 month to go to the peak and then go down. Of course, patients remain in the hospital for longer term, and especially in the ICU, but once they are here for 2, 3, 4 weeks, they will not be eligible to the trials once they have been recruited in one trial. So actually, the main difficulty is to be able to start a trial very quickly at the beginning of the outbreak, or not too late after the beginning of the outbreak, to be able to recruit patients during that month or these 3 weeks where you can actually recruit patients in one place. Otherwise, you will have to do the trials in many different places in the country or in the world, and it's much more difficult. So the first thing is to be prepared before the outbreak, and that's also what YY says. Singapore was hit by the SARS before, and they were prepared, which we were less prepared to in France, for instance, for research, because we were never hit by such, or at least not in modern times, by such an infectious outbreak. But the groups who have managed to do trials are also the groups who were prepared before, mostly, for instance, because of Ebola crisis before, like Alert in the UK or in Europe worldwide, and Reacting in France. So the trials were prepared before, or mostly prepared before the outbreak, so they were able to start quickly. But it's difficult to run trials, and it's in any case impossible to run trials for all possible interventions that someone would like to test, especially when the standard of care changes so quickly during the outbreak. The second point I wanted to talk about is not treatment but prevention, and clearly it is the most important in terms of public health to avoid the spread of the disease. It's important to have appropriate healthcare for the diseased patient, but it's very important to limit at the maximum the diseased patients. And in terms of research or clinical research, it's clearly the most difficult to do. It's very difficult to conduct clinical studies or nicely planned clinical studies for prevention. There have been some attempts to do preventive trials for preventive treatments like hydroxychloroquine. There is one trial with results available today. Many have started and have stopped after the publication of treatment results for hydroxychloroquine. Vaccine research is clearly most promising. We don't know if we will find one. I personally hope so. As far as I know, there have been no vaccine for coronaviruses so far. But there also has not been so much research into that. Concerning vaccine, already 9 studies exist with results, but all are observational studies. But 54 clinical trials are registered, and 30 are currently recruiting, mostly for prevention. 7 are for treatment, but so 47 clinical trials registered for vaccine. This is huge. This is a lot of work, and hopefully we get a vaccine. But of course, I can't know. YYs also talk about other interventions, and Frederic too. The easiest to see is social distancing, and then it takes different versions of social distancing. But social distancing is clearly a key in avoiding the spread of the disease. Then the most strict version of social distancing is lockdown, as we have had. Clearly it's effective, even if it's not so much evidence-based today, but clearly it's effective, but it has also a lot of consequences, and I guess Danny or Etienne will speak about economical and social consequences of the lockdown. So clearly we cannot stay forever in lockdown to avoid the epidemics. And then there are the other interventions, testing, contact tracking, and tracing. There are very, very few studies, but one good thing is that countries have adopted very, very different strategies from one country to the other, even from one region to another one. And this will allow, I think, this opens a nice perspective for research in comparing what could be effective or not. I think it's a real challenge for statisticians and epidemiologists to be able to do that properly, but I hope we will achieve that. And I know that we will try with Germany, but hopefully we could try with compare with other countries. Data exists, and so clearly I think it's an excellent thing to compare and to try to identify which type of testing, contact tracing works best. One important question is whether this is used on a voluntary basis, like it is in France today, or whether it is enforced, as in other countries. But this will raise also social or societal questions, which are not my area of expertise, but clearly this is something that we will have to study. And the same for levels of border controls and what we should do for border controls. Last, or before last, I wanted to have a word about modeling that YY and Frédéric talked about. I think modeling is an important part for policymakers. Then it has to be confronted to real data, and that's the statistician speaking. And of course, we see that often the uncertainty of models will encompass the truth. Not always, but often. But if we look at the individual predictions, they can be quite far from what occurs. And this is also because the models have a lot of parameters, and we lack, when we run the models at the beginning of the epidemics, we often lack a lot of information. We have to make a lot of assumptions, and of course, assumptions might turn out wrong. So my last point is that we need population-based research. There has been a lot of clinical research, and it's much easier to do, actually. Even if I said doing trials or running trials is not so easy, it's clearly doable. Population-based research is also doable, but it's more difficult, especially in an emergency context or in a crisis context, where most efforts will be directed at care, at healthcare. But it's something we should strive to do, and we should develop population-based research. For a long time, we were lacking a lot of information. We had papers from China, but mostly for patients who were already mild or severe diseased, and we had very few information about how many post-symptomatic, asymptomatic cases. So now we should more or less know that there are few asymptomatic, completely asymptomatic cases, but there are many post-symptomatic cases. And without those information, we lack proper parameters for modeling, for instance. So perhaps also a word about research. There are different aims of when doing clinical research or medical research in those crises. You can have the will to do research to guide care where you are quickly. And clearly this cannot be done on the same time scale or time frame as more, I would say, higher level, but it's difficult to judge, but longer term, larger scale clinical trials with, let's say, 28 days or 90 days outcomes. Those are very important, but they will bring information after the outbreak. So it's very valuable for other countries. The epidemic is not over at all. They will bring extremely valuable information for a possible second wave, assuming that I can define what second wave is. But if you want to do research that is embedded into action to change the standard of care where you are, you have to be very quick and to provide very quick results. And that's really a challenge to have the timing of research and the timing of the epidemics more or less aligned when actually they are quite different. Thank you, Dale. I will thank you, everyone, but I hand the word back to Dale.
Thanks, Raphael, and thanks for those insights. We'll move straight on to Professor Danny Qua to give us some economic perspectives now. Danny is the NUS, the Dean of NUS Lee Kuan Yew School of Public Policy. Thanks, Danny.
Thank you, Dale.
Just turn your video on as well.
Yep. Sorry about that. I was waiting for the central command to open that up. Thank you, Professor Fisher, and thank you, panelists, for setting such a wonderfully informed stage for me to come into this discussion. My job as a panelist is to talk about the economic situation that we find ourselves in, and in particular, against the background that my colleague at the Sociology School of Public Health has already masterfully laid out for you, the public health situation in Singapore. So to do that, peculiarly, I need to try and convince you that economic policy or economic action actually has a role here. And that might not be so clear to everyone, or if it is clear to everyone, it is for different reasons. The public health policy problem, challenge is clear. Keep people from dying. Keep your health system intact. Do not let it be overwhelmed by the epidemic. Where does economics step into this? So what I want to do in the time that I've got is first to lay out for you what the considerations need to be for a sensible economic attack on the COVID-19 challenge. Then I will describe for you what we're doing here in Singapore, and then finally talk about some things further on ahead, how we might turn COVID-19 around and leverage it for a brighter economic future for all of us. Now, to begin, we're obviously in the middle of a global pandemic. There is no good time for the world to have a global pandemic. Having noted that, 2020 might be one of the worst times in recent history. The global economy was already beset by great disruptions, sharp deglobalization, a harrowing, intense geostrategic competition between the superpowers in the world, practically class warfare between the rich and the poor, or at least great concern about income inequality in every nation around the world, and believe it or not, a growing disrespect for science and expertise. Yes, in 2019, we forget now, before the great COVID-19 outbreak, in 2019, the World Health Organization felt that one of the greatest challenges to global public health was so-called vaccine hesitation, the anti-vax movement, trying to get people not to buy into the idea that vaccination was a good thing. So against all this challenge, today we sit in COVID-19, 11.6 million people confirmed being infected, over 550,000 deaths. How does economics come into this? Well, you see, people interested in economics need to remember that this coronavirus is like any other virus. All it cares about is its survival and its spread. When it looks at us, for all the concern that in economics we have about inequality, when it looks at us, it doesn't see ethnicity or inequality or poverty or wealth. When it looks at us humans, for its survival, it sees us as food. For its spread, it sees us as its Uber driver. The economic challenge is to connect that observation with what we do in terms of generating value for the rest of society. Now, the way in which you deal with a virus who looks at us as food and who looks at us as its transportation is society is shut down. We've had school and work closures around the world in every single country, hundreds of nations. We have restrictions on international tourism and business travel. And as a result of all that, we have a sharp contraction in economic activity all around the world. It used to be that economists would think, oh, is this a demand shock? Is this a supply shock? Is this terms of trade? When we try to formulate a sensible economic policy against a challenge that sees us as food and as transportation, our economic policy must be similarly tailored. And that's where I land on how it is in Singapore, we're attempting to deal with this COVID-19 challenge. There is no question, there's no doubt around the world, this has been a huge shock to the global economy. The collapse in world trade has been 4% sharper than the 2009 global financial crisis. Singapore is an economy whose value creation hinges critically on our being a hub for international trade. You shut off international tourism, you shut off international travel because of restrictions on school work, international travel, crowds getting together. That has an impact on an economy like ours. Therefore, our economic policy has been tailored to try and deal with this. Singapore has, in dealing with the COVID-19 challenge, issued a series of 4 budgets in the last 4 months, each time upping the ante on how we deal with the COVID-19 challenge. You have to remember, compared to many transatlantic economies for which fiscal spending, deficit spending is an annual event, Singapore is a very different kind of economy. Even in the global financial crisis, at the end of the global financial crisis, we were running a balanced budget. So when Singapore turns around and issues 4 budgets in the space of 3.5 months, each time upping the ante to a point where we're spending 100 billion Singapore dollars, 20% of our GDP, on dealing with the COVID-19 challenge, we're talking about something very serious. We are taking this very, very seriously, and our economic attack on this has been correspondingly tough. There are 3 planks on which Singapore's fiscal response to COVID-19 has been targeted. And each of these planks keeps very sharply in mind what I said earlier about COVID-19's impact on an economy. The first of these planks is fiscal spending has targeted maintaining care and well-being of the population and supporting people's livelihoods. This has taken the form of cash support, a lot of which has been automatic to maintain expenses on people's livelihoods. It has attempted fiscal spending supports low-income households or households that are suffering from income reduction. We have deferred tax payment for self-employed. We have rental waivers. We have generated a whole range of fiscal actions to take care of the people for whom school and work closures have been hugely impactful. The second of these dimensions is employment support. We've issued programs on job support, on wage subsidies. The National Jobs Council has been scrupulous in looking for new opportunities and job openings. And the third plank of Singapore's economic fiscal response comes from the realization that we need to keep economic activity going. Yes, school and work closures in an attempt to take care of the epidemic, to dampen the epidemic curve, to flatten that curve, has been hugely important. But we also realize that we need to look ahead to when the economy comes down out of lockdown, and we need to have a stock of capital, a preparedness in the infrastructure of the economy, ready to benefit, ready, not necessarily to benefit, but ready to in turn grow when the global economy turns around. So Singapore's fiscal programs have looked at co-investment and risk sharing. It is engaged in loan deferment. There have been lowered interest rates and insurance premiums. Installment plans have been made flexible, and there's been specific targeting of tourism and travel industries. As you reflect on all of these attempts to keep the economy going over, I think you'll realize that these are not scattershot, shotgun approaches to just fiscal spending. These are targeted in a way that explicitly recognize all the considerations that my colleague, Professor Y.Y. Teo, has described for you. Yes, COVID-19 is a challenge. Here's how we're dealing with it. Now, we will see this around East Asia and the Pacific region, just as there has been a playbook that this part of the world developed, put in place following SARS 2003. This playbook is being rehearsed, adapted, modified across all of East Asia. So in Vietnam, we've seen 0 deaths from COVID-19, unexpectedly low rates of infection across East Asia, in a way that I find often surprises interlocutors that I engage with in the West, because right now it is the transatlantic region that is suffering terribly from COVID-19 infection and deaths. Let me conclude. Where do I go from here? Where do we go from here? I've described to you the structure that is the foundation for the challenge we face. It is density. Density of working and living together, not inequality, not blind spots. It is density that is critical for how we will need to deal with COVID-19 going forwards. Dealing with COVID-19 going forwards, there have been a number of approaches. One, we've seen around the world, a number of economies saying, well, we've had our shot of safe distancing, wearing face masks, we will begin to open up. And here's the critical thing. The second wave, which many of you are asking, when will that happen? It might have already happened. If you look at a curve of the new epidemics, daily new epidemics, yes, we've seen a sharp drop since May, but as of late June, confirmed cases of infection in advanced economies in the transatlantic region have already begun to pick up again. Whether this is truly a sustained second wave or not, it's certainly more likely that there's a second wave now than there is not. So we will need to be watchful. Singapore is doing this unlocking recovery in a measured, careful way with constant monitoring of the numbers, and in exactly the way that Professor Teo YY has described to you. We're keeping close track of this even as the economy starts to pick up. Let me conclude. As befits many economists, I have told the story that some people might think of as pessimistic. I'm actually not a particularly pessimistic person. What are the optimistic things we can look forward to? This COVID-19 pandemic has taught us, first, that digital technology, telemedicine, teleworking, all of these things are possible. We need to be creative and adaptive about how we leverage technologies that reduce density. Second, we need to have a new idea of resilience and efficiency. There's no point stretching central business districts to utmost 100% efficiency if that involves workers traveling for hours in public transportation systems to work cheek by jowl in a closed windowed office. We could potentially see, as a result of this, a flattening of Asia's super cities, because closed-in working together will no longer be so important. My time is up. What have I done? I've told you about the considerations that went into lockdown. I've told you about how targeted economic policy needs to be when it looks at these structural considerations, and I've painted you what the economy might look like going forwards. Thank you very much for your attention. Back to you, Professor Fisher.
Thanks very much, Danny. Nice presentation. So the final formal talk now is from Dr. Etienne Nugues. Your opening line, Etienne, is how to pronounce that. He's going to talk about sociological issues. He's from the Center for Sociology of Organization at the Paris Institute of Political Studies. Thanks.
Thank you very much, Dale. Yeah, it's named Nugues, but I forgive you, it's quite difficult to pronounce. So.
Oh, it's close though.
Thank you very much for having me in this panel. There are currently a lot of ongoing sociological studies addressing various social dimensions of COVID-19 epidemics, because if we've talked a lot about health issues, and it's quite normal in this context, the pandemic is really also a pan-social endemic. So I will try to raise some main sociological issues, knowing that the researches are still ongoing and we have not yet much results. So it's a broad picture, but I won't go into real details about this sociological research. I will have two times in this presentation. First, I will talk about social dimension of lockdown, and I will go to sociological perspectives on reopening the French society. First of all, I'm currently studying with some colleagues of mine the organizational dimensions of the epidemic and lockdown management by French public authorities. And if the general lockdown that occurred in France can be mainly explained by the lack of test devices and masks at the beginning of the epidemics, we can also present it as a very significant way in which French public authorities approach health and healthcare issues in France. We can draw three main dimensions of this way the French public authorities manage public health issues. First, and you will not be surprised, centralization. The decisions were mostly taken in Paris by the national government and were supposed to apply uniformly to the whole country without taking into account local specificities. Professor Batte told you about the differences in prevalence between French areas. The whole French was locked down. But we can also talk about density of population. The Parisian area is one of the most dense in France, but we have also rural areas where there are not so many people. And of course, socioeconomic conditions and political organizations, local political organizations, were not addressed during the pandemic management. Second dimension of this management is hospitalization. The attention and the focus of French public authorities and media was entirely on hospital care, to the detriment of ambulatory care. I mean by that general practitioners, paramedics and social workers who were not mobilized during the first stages of the pandemics. To give you an example, we have not precise data, but we know that the general practitioners' activity has reduced from 20 to 40% during the lockdown. And even if telemedicine and teleconsultation have known a huge increase, it didn't compensate the decrease in general practitioner consultations. And the third term was biomedicalization. Contrary to Singapore, the focus of French public authorities and French hospitals was on treatments, reanimation equipment, and to find a vaccine, and rather than on public health, broader aspects such as testing, tracking, prevention of the COVID-19, but also of all other diseases such as cancer, mental health issues, who were really overlooked during the pandemics and particularly during the lockdown. My second point concerns the effects and the consequences of lockdown on French society. We can see lockdown as what Marcel Mauss, a French anthropologist, called a total social fact. I mean by that it affected the whole of French society in all its aspects. Health, of course, and we've talked a lot about health, but also housing and living conditions, couple and family. We've experienced a huge increase in both divorces and separations during the lockdown, but also in pregnancies. So people were torn apart, or on the contrary, were going together. Work, of course, with the discovery by many French people of the advantages and disadvantages of teleworking, but also the effects on unemployment and partial unemployment, and school, with the stakes of distance learning, but also school dropouts. And we've got a huge anxiety about children who will have difficulties to go back to school and who have delays in learnings. And construction and labor and so on and so forth. We can address every social dimensions with a lockdown framing. And third, the lockdown did obviously raise the question of individual and collective freedoms. And we talked earlier about the tracking devices and how they raise this question about until where we can reduce individual freedom in the name of public health. But sociologists have been more focused on social inequalities and territorial inequalities between classes, gender, and age. If you look at the French map that Professor Batu showed you, you can see that the epidemic was the deadliest and the strongest in poor suburbs where live working classes who had many disadvantages with the epidemic. First, they work on the front line. It's people who are cashiers, delivery men, caretakers, and so on and so forth, and who were facing the virus and couldn't distancing. I don't like the word social distancing. I prefer physical distancing. Who could not distance from their clients and who were really facing the virus. But these people were also mostly suffering from chronic diseases who are comorbidities with COVID-19, and they also have housing conditions that are the most precarious. So they accumulated disadvantages to face this pandemic. And last but not least, in these poor suburbs, they mostly lack general practitioners and hospitals, so they couldn't go to simply and fastly to see a doctor if they encounter a problem. On that basis, I would like to turn to sociological implications of reopening the French society. If I go back on the governance side, there has been a complete shift in the way French public authorities have managed the reopening, and we look more and more like Singapore, even if we're not as good in prevention and public health managing, but we see that the French public authorities have shifted from a policy that relied mainly on lockdown to a policy that relied now mainly on the availability and massive use of masks and testing. Tracking is still under discussion because it raises, as I said earlier, a lot of questions about freedom and individual choices. But now we've got mask and test, and the idea of the government is to diffuse them and to make them available if a new wave is coming into France. Secondly, the center of gravity of healthcare has progressively shifted from hospital emergency and reanimation facilities to ambulatory care. And general practitioner got the double assignment to test people to prevent another wave on the hospital, but also to compensate the delays in treatments of other diseases resulting from the lockdown. People delayed their chronic condition treatment, they delayed vaccination for other diseases, they delayed mental issues consultations, they delayed a lot of things, and now French general practitioners are trying to cope with these delays. Secondly, as I told earlier, the lockdown was indeed uniformly imposed to all people and territories, even if it gave rise to diverse appropriations according to individuals and territories. But the reopening has multiplied and diversified social conditions. At both extremes, some people have kept their lockdown habits, while others have resumed their previous life as if nothing had happened. But the vast majority is struggling with in-between situations, with remainings from the lockdown and partial reopening. If I take the example of work and school that I have myself experienced, as many people, during the lockdown, many high-skilled workers experienced teleworking, and polls show that a majority seems to have enjoyed this new type of work, but it depends on whether or not there were children at home and on the repartition between domestic and professional work within the couple. The partial reopening of schools and workplaces in June produced conflicting imperatives on workers who were asked to return to work at the office while their children were not schooled. It raised a series of open questions that sociologists are currently addressing. What is the magnitude and the persistence of lockdown effects on social conditions and behaviors? And how do these effects vary according to social background, gender, age, and territory? And we have a lot of research going on these different issues, because as the experience of COVID was so socially differentiated, we have to thoroughly look at what conditions make the lockdown easier or worse for people. And I would like to conclude with a thought on the second wave of the epidemic that could occur in fall. The government seems to exclude any possibility of a general lockdown, but seems to opt for a limited and targeted lockdown, where the territories in which the epidemic is strong will be quarantined, but the surrounding territories wouldn't. This raises the question of the social experience of normality, when the threat seems both to be there and not there. In the recent weeks, we have witnessed what we may call a return from the repressed, to copy psychoanalytical terms, And for example, during the French Music Festival on June 21, we saw unmasked people crammed into narrow streets to party all night long. And when they were interviewed by journalists, they said, it's over, we don't care about the COVID, we need to live a normal life, and we don't want to live in a complete and total fear of what could happen. And the media insisted on the lack of precaution and of responsibility. That would be another proof of the French lack of individual and collective discipline. But to me, it has more to do with this hybrid situation I described earlier, where the normal and the exceptional coexist in every dimension of the social and individual life. And managing this hybrid situation supposes a great sense of creativity, adaptability, and proportion, as Professor, as Professor Kwa told you earlier. And we need to see this adaptability both from public authorities, organizations, and individuals. And to encourage and organize that creativity, we need in France to push further the decentralization of governance and put our trust in local and community organizations rather than deciding all in a ministry in Paris and pray for everyone to align with what we've decided in the government. So thank you very much, and I'm looking forward to your question.
Thanks, Etienne. Now, we've got quite a lot of questions, and we're supposed to finish in 10 minutes. So I've had permission to push it for another 10 minutes. So if those of you on the panel and in the audience don't mind staying on till 40 past the hour, then we might get through. We won't be able to ask all the questions, but I've got a bit of a cross section here. There's one from David Teo from International SOS. It's about second waves, and I'm asking YY and Frederick. With the de-escalation of measures in many countries, second waves are discussed and seen: Beijing, Victoria, specific locations, UK, Germany. However, we have not seen a defined classification what constitutes a second wave, e.g. a jump of 100% cases on over a sustained period. So maybe YY first, what is a second wave? I don't actually like the terms personally. How low does it have to go and how high does it have to go afterwards?
Thanks, Dale. So like you, I don't actually like to think about second waves because it is what it is. If there is an outbreak and there is an escalation of cases, we deal with it regardless of whether it was part of the first wave or whether it was indeed that the first wave has diminished sufficiently and then now you see a slight increase, a second bump of sorts. So there is no classical definition of second waves. And I believe even colleagues from the World Health Organization indicated as such that we don't go about describing what really constitutes a second wave. But if you want really to think about an outbreak, there is a situation where you are able to contain the first explosion of cases very well, such that there is a clear diminishing trend in the number of cases in the society, in your country, in your region. And then for some particular reason, either because certain measures have been relaxed, and then you start to see a very rapid escalation of new cases coming out. And that is what people generally define as a second wave. But from a public health perspective, whether it is the first wave, an extension of the first wave, or indeed a genuine second wave that has emerged, we have to still treat it as if that there is an escalation of community transmission, and we take care of it accordingly. But I would also like to hear inputs from our colleagues in France as well. Over back to you, Dale.
Frederick?
Yes. I think there's two questions. First, do you think we can face the second wave? And I think the answer is yes. Whether it's a new wave or the prolongation of the first wave. Why? Because we have taken a serologic survey in Paris, and so we have performed a lot of serological testing. And so far, the percentage of people who became positive is quite, it's not huge, it's around 50%. So the percentage of potentially protected people is quite low, and so the probability of a second wave is not close to zero, basically. And so the probability to get a second wave is, it's quite high. How can you define a second wave? So it's very difficult to define what could be a second wave. Maybe we can define the second wave compared to what occurs in the first wave. And so we can use, for example, virological parameters, and for example, the reproductive viral ratio. The reproductive viral ratio in France was close to 3.3. And here in France, we found that if a second wave occurs, the reproductive viral ratio cannot be higher than 1.5. And so we are looking at, the situation and whether, the number of cases increased and became between higher than 1 and from 1 to 1.5. And so this will be a second wave. But I also agree that it won't be exactly what occurs during the first wave. It's going to be, some cluster, couple of clusters almost everywhere. And so not a huge wave at the end.
Thanks. Raphael, you spoke about non-pharmaceutical interventions research. To me, the biggest question out there is about schools. It's the one people really don't know what to do with. How would you go about research as to whether schools should be closed or not?
I think it's first an excellent question, and I have absolutely no answer.
Yes.
But clearly, it's not what people have been doing research on how to. There have been modeling, even for school, models have been micro-simulation or agent-based modeling has been used. But either we could go further with models, but then we have data today that we didn't have in February, for instance, in France. So people could use data, more recent data to try to refine the models, but they remain models. I don't know in Singapore at all, but in France, we have been always reluctant to do research on institutions, interventional research. One solution would be that you could have different regions or, I don't know, administrative cities who would implement different strategies, and then let's see. Actually, I fear people wouldn't do that in France, but that's doable. I just believe that what we are ready to accept for health, for our healthcare, we are not ready to accept for our children, for instance, if they are not diseased. But clearly, there is a potential for intervention research, and
yeah, it's a question that needs to get answered somehow. Danny, there's a couple for you. Wendy Kwok writes, from a public health policy and strategy perspective, what are some of the, no, that's not what I wanted. Wrong question. We'll come back to that. Danny, I'm very impressed with the 20% of GDP Singapore allocated towards social protection measures that contribute towards securing the country's socio-economic priorities. What can smaller and perhaps more fragile economies do at a minimum or as a first step, given significantly smaller budgets and capacities?
Thank you. That's an excellent question. First, to be very clear, we're talking about keeping the economy, whichever economy it is we're talking about, ticking over. We're not trying to turn an economic collapse into a boom. So we've got to manage expectations properly. Now, on this front, Singapore has been blessed. We've got high savings accumulated from the past. We have reserves that with presidential approval, we've been able to draw on. And so we've been able to put this fiscal firepower into effect with compared to the rest of the world, with little damage to our credibility as a borrower and with little damage to our bottom line in terms of debt. One thing that other nations will have to be careful about is not to lurch from a COVID-19 emergency into a debt crisis. In the 2008 global financial crisis, we had a financial crisis, and then all of Europe afterwards had a sovereign debt crisis, which kept the economy under for a long time. So one needs to manage expectations properly. Having said that, we need the international community to help. No single nation by itself is going to go it alone. We need to put in place an international financial architecture that helps all nations risk share and be able to spread the pain of the borrowing around. And I strongly urge that international coalitions of the capable get together to try and build this. The value for money in terms of what Singapore has been able to do, I think is clear, and we need to expand this idea to other economies, other nations. Thank you, Dale. Back to you.
Yeah, so building on from that a little bit, there's been a lot of money handed out, which from a health point of view is essential. We can't have any disincentives to the societal behavior that we need to fight the virus. But what's going to be the long-term the long-term consequences of propping up companies, handing out money to individuals for no work? What's the price at the end of all this?
Okay, the first proposition I go into this with is it's not good for business if you kill your customers and you kill your workers. You've got to have people around to do business with. So first priority is keeping our people safe. Historical evidence actually shows that those US cities that did the most for keeping their local economies turning over, keeping their people safe, actually rebounded much faster and much more robustly afterwards. So first piece of evidence is we need to take into account that historically it is a good winning proposition to keep things going. The second thing is we certainly do not want to have what from the global financial crisis we think of as zombie companies or zombie banks, things which shouldn't exist, continuing to do so, simply living off of infusion of state funds. And my view is that we need to look after that as our recovery continues to become more robust. We will have to let the forces of creative destruction once again kick in, but we've got to make sure that our economy is not flat on its back. Our economy, the world over, is seeing a turnaround of up to 7 percentage points in growth. In Singapore, we've been able to control that to much less than that. And when you think about how open our economy is, how reliant it is on international trade, it's already an achievement. And we need to stay the course on that. But yes, Dale, I agree with you. The Schumpeterian forces of creative destruction, letting companies that are not actually viable go under, will be an important part of the post-recovery landscape, no question.
If I may intervene on that point, there is a current debate in France, knowing if the money that has been spent and will be spent to relaunch the economy should be directed in a new direction and allowed to develop more environmental companies, or if it has to go on big traditional companies in France who are not environmental friendly, or not really environmental friendly, and the way France for now has managed this issue is to launch money without looking at and without giving conditions to giving money to companies. And so we're back on the world before COVID-19, and with no changes in the way the public money is used to implement a policy would be better for our environment. So that was just a small point on this issue.
And while I've got you, Etienne, I was going to throw you the question from Wendy Kwok as well, and maybe YY wants to add on afterwards. From a public health policy and strategy perspective, what are some of the critical learning points gleaned from the COVID crisis, which we should consciously build into our healthcare policies and strategies so that we're more prepared for future pandemics? So you've already pointed out some of the social disasters that weren't really predicted, I guess. Can we do anything preemptive next time?
Yeah, I think that what the COVID-19 crisis revealed is that France is not very good at public health. I mean by that prevention and community organization and promoting health. We're really, that's what I call biomedicalization and hospitalization. We're really about cure, and not much about care, preventing. And as the COVID-19 epidemics came, we went back on what we are strong. It means hospital and biomedicalization. But if we want to face the next pandemics or the next public health crisis, we need to invest in public health, and invest not only money but also organization and political implication, because we are not very well organized to promote health and to prevent right now. I don't know if the two public health professors agree with me, but that's my point.
If I may say a word.
Sure. Who's that?
I completely agree. My discipline belongs to public health in general, but I am a statistician, and I'm doing clinical research actually. But we are very behind many countries in terms of general public health, even in terms of training. The public health professionals are mostly trained on epidemiology, epidemiologic methods, statistics, clinical research, much more on prevention. Even in an evaluation point of view, I only advise doing research or research action to evaluate policies, but we are not much trained to that. And as you, Etienne, very rightly said, we are much better trained on clinical research, care, ICU, organization of care, and this is where we went naturally because we are trained to do that. Thanks.
Why?
Thanks, Dale, and thanks to our colleagues from France for sharing that. I think I will start off with this point, that the ability or inability for a country to respond during a crisis, particularly a health crisis, it's a function of the work and investment that have been put in previously. And linked to this, I will raise 5 points. The first, it's really what our colleagues in France have mentioned, the focus on primary care. But I want to expand beyond primary care, and not just because our colleague from France mentioned it's a lot on hospital care, but COVID has shown that the first line of defense in many instances is actually primary care. But I want to move beyond primary care, but really focus on the universal healthcare, because universal healthcare provides the safety net such that there is no disincentives for people coming forward, because there's no fear of any catastrophic poverty as a result of seeking care. And it doesn't matter whether it is an infectious disease outbreak or it is any healthcare crisis. Universal health coverage must remain one of the fundamental principles in coping with a health crisis from a policy and strategy angle. The second must be that public policies that are made has to be based with evidence. We have seen many countries, the government adopt policies that actually are not grounded in science or evidence. But some of the countries that have done very well rely on what is the latest knowledge around modes of transmission, modes of treatment, the best form of treatment, what are the best way to diagnose, and the right use of serology. So the ability to integrate evidence in public policy, it's a very important principle that governments worldwide need to start thinking about it. And that ties in very nicely with the third principle. And the third principle is the partnership between the policymakers as well as with people who are generating the science, providing the evidence, the academics. So the partnership between academics and policymakers is absolutely essential. And we have again seen how countries that have done well, there is a good flow of information from the scientists, from the clinicians, back to the policymakers to guide policy making. And it's not just the academics, the partnership also with community leaders and also with the private enterprise, because at the heart of it, this needs the cooperation of businesses, as what Professor Danny Kwa has mentioned. This needs the cooperation of the people. And you need to understand what makes the people listen and behave in a responsible way. What makes a company, a corporation, and the private enterprise behave in a particular way to protect jobs and instead of laying them off. The partnership is very important. And this partnership has to be built up during peacetime. You cannot wait for a crisis to develop and then you start to develop this partnership. It doesn't work. The trust is not there. I talk about the trust, and the fourth point I wanted to raise is on communication strategy. There are 4 groups of people where communication is absolutely important. Politicians to policymakers. The policymakers need to know what is the stance that the country needs to adopt, and many of the times these are decided not by the policymakers themselves, but by politicians. We have seen that in many countries. The second group is communications to the healthcare workers and the management of healthcare institutions. They need to know what are the rules, what are the guidelines, how do I protect, is there adequate personal protective equipment, medical drugs, and so on. Communications to community leaders, I talked about earlier on. And finally, the communications to the general public. How should individuals behave in a responsible and in an ethical manner as well? And the last point I want to talk about is really the value system, the culture around the society, around the trust between citizens and the population and the policymakers. That trust, that value system is very important to preserve. And I started off by saying that ability or inability to respond during a crisis, it's dependent on what you have put in during peacetime. I end off with the same point. Out of the 5 principles that are highlighted, you would notice that you cannot wait until something has happened, a crisis has happened, before you start to develop this system or you start to put in the investment. So when you ask about the critical learning points from a policy and strategy angle, I see that these 5 points are very important that we have learned in Singapore, in France, but equally I have seen countries who have done well and countries who haven't done well on the background of this 5 principles. So over back to you, Dale.
Thanks, Wai. I'm going to take one more question, and I want to direct it to Professor Frederick Batu. It's about border closures. There's been a couple of questions, border closures, border openings. There's been a couple of questions about that, one from Mia Hass-Goldberg, another one, Ewan Sue Choi, and a few others. I'll try and paraphrase it into, do we still need border closures? I think most of us would feel that it was a time to prepare, not a long-term plan. And secondly, how important is it to have a consolidated international or regional approach to contact tracing rather than than contact tracing might stop at the border. How is Europe doing this? Because they're clearly leading the way in opening borders.
Thank you, Dale. It's a very difficult question, basically. First of all, in Europe, because all the public policy are quietly the same, and because the COVID-19 epidemic has hit the whole Europe almost in the same times, and except Sweden, who has decided not to protect his population using the lockdown strategy, all the European countries have decided to open the border. And so, you know, the epidemic goes down in each European country, and so it makes sense. This policy makes sense. The question is, what if regarding the situations which occurs in, for example, in Brazil or in Africa, and so what will be our policies? You know, as you say, as you mentioned, it's very difficult to live without any contact with other countries. And so we have to get prepared to live with the virus for months and even for years. And so we have to organize ourselves to be very aware and careful, especially for people who visit us, and you know, to securize our border more than close the border, and to organize a system where we have a tracking system already, and people that comes into our border can be tested, and depending on their medical status, then they can enter the country or stay on quarantine. And so I think we will have to live with the virus, and there's no way that, and you have some very good advice at how, you know, terrible the lockdown as, you know, for the economics and so on. So so we organize ourselves to be prepared and to control all the people that come, but we are welcoming everybody, and of course.
Okay. Okay, well, I think we've gone around 20 minutes over, so that's very generous with your time, and I see most of the participants have stayed on, so that's been fantastic. I was going to give a sum up, but I made a strategic decision to invest more in the questions rather than repeating what everyone else has said. So with that, I'll close. I'd like to thank the panelists. I'd like to thank the people behind the scene, Darun, Wendy, Crystal, Mariana, I'm sure there's others. Thanks all for all the work you've done here. Not easy to coordinate a bunch of people like this, so well done. Good night and good morning to everybody.
Thank you, Dave, for animating the session. Thank you.
Yes.
Thank you very much.
Thanks, everyone.